Dear audience, dear chairs, let me introduce my PhD topic, which is novel insights into the oral systemic health axis. My name is Ellay Gutmacher. I'm a PhD and dental student. My supervisors are Andrea Brody and Ako Zhembery. My SMS is Petrana Martinekova. My statisticians are Silvia Kish-Dalla and Gergely Agoc. My vision is to facilitate global healthcare by better understanding the oral systemic health axis, and my mission is to provide evidence that saliva can detect systemic diseases. Currently, we have two ongoing projects. The first one is investigating the salivary levels of Fusobacterium nucleatum in patients with colorectal cancer by the methodology of systematic review and meta-analysis. This project has started in September last year, and the co-author for this project is Balin Zsombor-Sárai. Colorectal cancer causes more than 930,000 deaths per year, and this is estimated to grow to more than 1.6 million deaths by 2040. Screening tests such as colonoscopy can prevent early colorectal cancer by detecting malignant polyps and removing them. However, unfortunately, colonoscopy has geographic barriers that contribute to the late diagnosis of the disease. And in addition, it is an invasive, uncomfortable, and potentially harmful procedure. Just as an example, in the USA, nearly 22 million risk individuals have never been screened for colorectal cancer. We know that Fusobacterium nucleatum is an oral pathogenic bacteria that is associated with periodontitis. It was found that the bacteria also accelerates different types of cancer, such as breast and pancreatic cancer. Recent studies showed that the bacteria is found in the colorectal tissues of patients with colorectal cancer and polyposis, and that the higher the abundance of the bacteria in those tissues, the lower the survival rate of the patient. Therefore, we suggest a novel method to detect colorectal cancer using saliva samples from which we can quantify the DNA levels of the bacteria. Our vision is that the risk individuals would be able to diagnose themselves from home using those simple saliva samples. And this is why our aim is to investigate the diagnostic and prognostic value of salivary Fusobacterium nucleatum to detect colorectal cancer patients. So we asked, is there a difference between colorectal cancer and healthy or precancerous patients in the salivary Fusobacterium nucleatum DNA levels? To answer this question, we used the PRECO and the PERT framework. The PECO framework is in order to investigate the association between the bacteria in the saliva and patients with colorectal cancer, and for that we hypothesized that patients with colorectal cancer have significantly higher levels of the bacteria compared to healthy individuals as well as precancerous patients. And to investigate the diagnostic accuracy of the bacteria to detect colorectal cancer patients, we used the PERT framework, and for that we hypothesized that salivary FN can accurately detect colorectal cancer patients. We conducted our systematic search on November 25 last year on 4 databases with the following search key that is composed of 4 domains. And we started with nearly 14,000 studies and finished with 12 eligible full texts. Here, let me introduce our results. So here we investigated the presence of the bacteria in saliva among colorectal cancer patients and control groups. This is important because patients with colorectal cancer usually show the symptoms at late stages of the disease. So early detection opens up more treatment options and also increases the likelihood of the successful outcomes, and by that it can save lives. So to assess this outcome, we used the odds ratio with 95% confidence interval. And here we included 5 prospective cohort and case control studies with nearly 1,000 patients divided into the healthy and the polyposis control subgroups. The heterogeneity was 0%, which is very low heterogeneity between the studies. And the pooled odds ratio for the presence of the bacteria in the saliva is 43% higher in patients with colorectal cancer, and this could be clinically significant. However, it did not reach the statistical significance yet. Here we investigated the relative abundance of the bacteria in the saliva among colorectal cancer patients and the control groups. To assess this outcome, we used the mean difference with 95% confidence interval. and we included 5 prospective cohort and case control studies with nearly 500 patients divided into the same control subgroups. The heterogeneity was 0% as well, and the pooled mean difference for the relative abundance of the bacteria in the saliva was minus 0.04, which is neither statistically nor clinically relevant. The strength of our study was its novelty. It focuses on vulnerable population. We could include individual patients' data, which allowed us to further interpret the results. And we could include also studies from different continents. The limitations were the differences in the measurement of the bacteria levels, and also the low number of the eligible studies due to its novelty. So based on our results, we could conclude that the presence and relative abundance of the bacteria in the saliva are not associated with colorectal cancer. For the practice, we imply that salivary FN alone as a biomarker should not be recommended, and for the research, we imply that other markers that can replace colonoscopy should be investigated. This is the progress of our first project. Currently, we finished with a manuscript, and we waiting for internal review. We plan to submit our project to the Journal of Dental Research. Our second project is evaluating the diagnostic accuracy of salivary C-reactive protein in neonatal sepsis by the methodology of systematic review and meta-analysis. This project has started in November last year. So every year, about 3 million children die in the first month of their life, and about 98% of those deaths occur in developing countries. Neonatal infections, including sepsis and meningitis, are estimated to cause around 420,000 deaths every year, with a mortality rate ranging from 9 to 20% in the case of severe neonatal sepsis. The signs and symptoms of the disease are nonspecific, and this often results in unnecessary antibiotic treatment for the neonates. We know that serum C-reactive protein plays an important role in the treatment decisions of neonates with suspected sepsis before receiving the blood culture results. However, it relies on blood samples whose processing may take several hours due to the laboratory support, and in addition, it may lead to phlebotomy losses and moderate pain in the neonates. A recent study showed that C-reactive protein could be easily and non-invasively obtained from saliva, and that it can also accurately predict abnormal serum CRP levels. This is why we want to investigate the efficacy and performance of salivary C-reactive protein for the diagnosis of neonates with sepsis. Our clinical question is, could salivary CRP accurately detect sepsis in neonates? To answer this question, we use the PERT framework, where the first reference is the blood culture, and the second reference would be the serum CRP. And we hypothesize that salivary CRP can accurately diagnose neonatal sepsis. Our clinical implication is that salivary CRP can accelerate neonatal sepsis detection. And currently, we are working on the search key of our second project. And to summarize, we plan to submit our first project in the beginning of next month, and the second project next year. And I want to thank you for your attention with a quote from Albert Einstein: "The most beautiful thing we can experience is the mysterious. It is the source of all true art and science." Thank you.
Thank you very much.
You mentioned in the first study that the included studies has heterogeneity because different countries or different words part was included or something you mentioned. Mm-hmm. I'm just curious because both the oral cavity and was the exit of our digestive system, I think the bacteria biofilm or bacteria growth can be infected or influenced by what is the on the different area has different tradition for what they eat, for vegetables, meat, and other things. So both of them could be influenced by that. So that maybe causes heterogeneity, and maybe this is caused by the insignificant result. Can you confirm this? So we understand that both. I think that both the disease can be affected by what you eat, and also the diagnosis part could be.
Thank you. So yes, you are correct. Actually, this was not a limitation. This was advantage of our project, because this is how we could generalize the abundance of the bacteria even in different cultures. Yes, it was also seen in some of the studies. For example, in Italy, we could see that the patients had the same relative abundance of the bacteria in both the control and the colorectal cancer group. But there are not enough studies to really confirm this, because it's a really novel study when concerning the saliva. But the Fusobacterium nucleatum, there are other studies that look at the bacteria in the colorectal cancer itself, and this is a different topic. But this topic is it's too novel for giving an answer.
Could you show us your first forest plot?
Yes.
How do you explain the difference between the first and the second part? Because if we see the control polyp, it seems that the results are almost statistically significant, but I know that it's not enough study.
Mm-hmm. So the question is, what is the difference? How come the significance is so different?
Yes, because I would assume that if the control is healthy, it will be more on the right side, the results.
Mm-hmm. I'm not 100% sure if I understood your question, but maybe I understood. So the presence of the bacteria was almost the same in all of both in the control and in the...
It was higher in the...
in the color, yes, it was higher, but it was very minor. For example, it was 1% difference, so it was very, it looks like it is almost significant, but actually it was basically almost the same. There were, most of the studies, there was exactly the same, almost exactly the same abundance of the bacteria in the saliva.
Is there any difference between regions regarding the prevalence of colorectal cancer? So let's say in Asia it's more frequent or less frequent than in the US?
Mm-hmm. Thank you for your question. I am not 100% sure about the prevalence of colorectal cancer in the world. I just know that in developing countries, for example, there is higher incidence of non-detected colorectal cancer, because there is as I said before, the geographic barriers of colonoscopy, and also it's not so cheap and uncomfortable. So in developing countries, it's harder to detect. So this is also one of the aims of these projects.